Welcome to the JCIH podcast, Health and Communication Distilled, a podcast of the Journal of Communication in Healthcare, Strategies, Media, and Engagement in Global Health. Each 10-minute episode features conversations with our authors on translating their research findings into practical and policy recommendations that will ultimately improve patient, community, and population health outcomes.
Hi, Dr. Olagoke. Welcome to a new podcast of the JCIH podcast, Health and Communication Distilled, a podcast series from the Journal of Communication in Healthcare, Strategy, Media, and Engagement in Global Health. My name is Roshni Ashik, and I am the current Communication Technology and Social Media intern for Spring. Today, we have with us Dr. Olagoke, who will be discussing her journal article, The Effectiveness of a Religiously Framed HPV Vaccination Message Among Christian Parents of Unvaccinated Adolescents in the United States, which you published online in January 2022. So, hello, Dr. Olagoke. Thank you so much for being here with us today. Would you like to start by introducing yourself a little more to our listeners and also summarizing your study in a few words?
Thank you, Roshni. I'm very happy to be here. It's a great privilege and opportunity to share our research with the world. My name is Ayokunle Olagoke. I currently work as an assistant professor at the University of Nebraska, Omaha, where I teach mostly health communication, health literacy, public health, which also form the center of my research. This particular study was published early this year, where we looked at the effectiveness of religiously framed HPV vaccination message. So what we basically did was conducted a randomized control trial where we randomized some parents to receive the religiously framed HPV message. There's a message that has religious theme, which I think we'll talk more about it. And then we also randomized some other parents to receive the CDC HPV vaccine information statement. Then at the end of the day, we tested which of these messages is more effective in persuading mothers to receive the vaccine for their children, parents to receive the vaccine. The result shows that religious parents who received the religiously framed vaccination message also reported a higher intention to vaccinate their children compared to religious parents who received the CDC message.
So, would you mind telling me the time when and why this topic became your area of interest?
Yeah, that's a very interesting question because I think it's a layer, like a buildup of several years of studies that kind of culminate into having this particular study. But one of the things that really stood out for me is in my journey to HPV vaccination, I realized that religiosity is the third most cited driver of HPV or even vaccine hesitancy. So religiosity is cited as like the third most cited reason why people decline vaccines, meaning that religiosity is very powerful. We can't ignore religiosity if we want to get people vaccinated. But then I realized that most of the messages that are created for HPV, they don't have religious themes. They are mostly secular messages. So like the CDC messages or messages talking about the symptoms, the signs. So even though religiosity is a big factor, we're not addressing religiosity as we should. Most of our messages are just focused on the secular themes, the big facts, the figures, the prevalence, and things like that. So I thought if religiosity is a big deal, why don't we create what I call equitable messaging? Why don't we have a religiously framed message that would address, religious factors targeted at vaccination? So I think that was when I started thinking of, okay, how do we build a religiously framed message that will capture that audience? If religiosity is my reason, if religious beliefs, and there are lots of religious beliefs. So this particular study did not address all religious beliefs, but it addressed two important religious beliefs, which I'll talk about more as we go on. But we did a quick surveillance where we're like, which of these religious beliefs is the most cited? Because religiosity is very complex, it's multidimensional. And then we found out there are two main reasons that people cite. Number one, the fact that getting HPV vaccination is like getting a license for my child to be promiscuous. So if I give them the vaccine, I'm more or less licensing them or giving them the go-ahead to be promiscuous. So because it's a religious belief that promiscuity is wrong, and if I'm a religious parent and I let them get the vaccine, then I'm endorsing promiscuity. The second religious reason that seemed to come on top of our list was parents citing the fact that if we get the vaccine, that means we don't trust God to be able to protect our children. So if we trust God to protect our children, we should not get a vaccine, because that means we're putting our trust in the vaccine. So those were the two main religious beliefs that we try to address in this particular study.
So I would be very interested to know the ethical challenges you faced in drafting faith-based messages and the ways you overcame those.
I think that's a very good question in terms of the ethical dilemma. So because there are strong religious beliefs, like I said, against the vaccine, using a religious theme, using scriptures to justify why parents should get their children vaccinated, faced some sort of pushback from some religious groups. One of the main pushback we faced was some people found it offensive because HPV vaccination, like I said, is seen or is perceived as a license to be promiscuous. So using scripture to justify why you should get it is seen as offensive by certain groups. So one of the ways we're able to navigate that was to include religious leaders in the creation of these messages. So there were lots of refinement where we had a strong collaboration with community leaders who are also religious and faith leaders who helped us to sort of flatten those curves around places where we could have hiccup, where people found offensive. We also, some of the practical suggestions they gave us is to direct people to their healthcare provider, give people the opportunity to verify whatever information, whatever recommendation or inference we're drawing with healthcare providers. So we added that phrase where we ask people to verify, and speak with their healthcare provider. One of the other strategy we used is what we call uncovering a flaw in a particular reasoning. Is one of the ways of addressing inaccurate information that is spreading. So you try to uncover a flaw in a particular reasoning, which involves going deeply into religious stories, religious documentation, to see that if is this reasoning actually true? Can we find other scriptural references that sort of justify what you're saying? If you're saying that taking a vaccine means you don't rely on God for protection. So we have in our team people who are very vast in religious knowledge, and they're able to find other aspects of the scriptures, aside from the stories that we use, that shows that God is not against the use of, medicine, and God even instructed in some places that people should use herbs to help them feel better. So we're able to uncover flaws in those inaccurate reasoning to sort of justify our point. I won't say we did a perfect job. I think it's something that is a conversation that is ongoing, constantly helping to see through the multiple lens that religion offers, and then seeing healthcare through the lens of religiosity.
Dr. Olagoke, what do you think is the role of religion in policy and practices around HPV vaccination?
That's quite an important question. I think one of the basic things that I would like to see more of in the healthcare is including religious leaders in every phase of policy development. I'll say, don't just create policies and call them to champion it. So, which is like one of the things we do. We go through the policy phases, create the policies, and then we are like, Let's find trusted religious leaders who would champion this policy we have created. But I don't think that's the right model. I think they should be involved from the scratch, from the creation phase. They should be involved in even contextualizing this to HPV vaccine or even any type of vaccine. They should be involved in the development of the vaccine. Yes, they should be given the opportunity to question the process. So we don't just go through the whole vaccine phase and then we create a vaccine and then we are done with it and then it's approved and then we come to religious leaders and say, hey, we know you guys are trusted. We need you to go tell your people that this vaccine is good. I think we should do better in involving them in the process, allowing them to question the process. I also think we should do more in terms of not just chasing inaccurate information, but doing a lot of education, for faith leaders and including religious and faith leaders in strong education processes.
In reference to your research, would you like to share what implications your study can have on policy and practices around HPV vaccinations?
Yeah, I think there are quite a number of implications for this study. First of all, the most obvious is equitable messaging. So this study shows that there is no one-size-fits-all type of message. The other implication is understanding that religiosity is multidimensional. We examine multiple dimensions of religiosity. One of the tools that we use in classifying religiosity is the Duke scale, the Duke index, that talks about organizational religiosity, which is the popular one. This is usually measured by attendance in religious services. Then non-organizational religiosity, which is private, and then intrinsic religiosity, which is also very private and shapes belief. A lot of our participants have more intrinsic religiosity. These are people who may not attend religious services, so you may not be able to capture them. So one implication of this is, how do you capture religious people, faith-based? How do you create faith-based intervention for people who do not even attend a religious? So a lot of faith-based interventions for HPV they are very center-based or venue-based. You have to come to a church, you have to come to a mosque, and then they deliver the intervention. But we have a large group of people who are very religious, who practice intrinsic religiosity, and they do not attend centers or venues or anywhere. So these messages, this type of messaging that we created can reach anybody, regardless of whether you attend a center or not. So the message that we created can sort of break through the barriers of center-based interventions. So I think that's one of the strong implications.
Thank you so much, Dr. Olagoke. This was all from my side, but in the end, I would really request you to share some closing remarks with our listeners.
Thank you so much for the team for putting this together. I think one of the things that we should always remember is that attaining health equity is the role of everybody. It's not just the role of the patient. We as public health practitioners and researchers should always do all that is within our capacity to create that equitable messaging and equitable intervention that would help patients to attain the perfect state of health that they're trying to attain. It's never the job of one person. It's a collective job. It's something that requires collaboration. The more we work with the community, the more we understand population, the more we're able to create solutions that are meaningful and that the patient and the population we're trying to reach will find useful for them. So thank you.
Thank you so much.
Thanks for listening to the JCIH podcast, Health and Communication Distilled, a podcast of the Journal of Communication in Healthcare, Strategies, Media, and Engagement in Global Health. Follow the journal on Twitter at JCIH Online for news about the articles we publish and other resources. That's JCIH Online on Twitter.